Today, we're going to talk about something called Barrett esophagus. Now, you might not have heard that name before, but I guarantee you're familiar with what often causes it: heartburn. We're going to break down the link between that common burning feeling and the risk of something more serious. Okay, let's jump right in.
So let's just start with a question that's probably on your mind. If you're someone who's been dealing with heartburn for, years, you've probably wondered, is this just heartburn or is my body trying to tell me something? It's a really important question.
So what exactly is Barrett esophagus? Well, in the simplest terms, it's when the lining of your esophagus, that's the tube connecting your mouth to your stomach, starts to change. The normal tissue gets replaced by a tissue that's a lot more like the lining of your intestine. And what's really interesting is that doctors can actually see this change. During a procedure called an endoscopy, it shows up as this very distinct salmon pink patch of tissue.
Okay, so how does this happen? Well, it all starts with that nagging chronic acid reflux, or what doctors call GERD. Let's really dig into this connection, from that burning feeling in your chest all the way down to a specific change happening inside your cells. Here's a fantastic way to think about it. It's kind of like getting a callus on your hand. If you keep rubbing the same spot, your skin gets tougher to protect itself, right? Well, your esophagus is doing the same thing. It was never designed to handle harsh stomach acid, so when it's constantly being splashed by it, it says, okay, I've got to protect myself, and it starts to change into a tougher, more acid-resistant type of tissue, just like the kind you'd find in the intestine.
And this doesn't just happen overnight. It's a sequence of events. First, you have that chronic acid exposure from GERD. This leads to constant inflammation, which is a condition called esophagitis. Then, for some people, that ongoing inflammation triggers the cells to actually transform into a different type. That final cellular change, called intestinal metaplasia, that's Barrett's esophagus.
But here's the thing, not everyone who has heartburn gets this condition, not even close. So that begs the question, why do some people get it and others don't? Well, it turns out there are some very clear risk factors that make it much more likely. Let's take a look at who's most affected.
So the profile for higher risk includes things like being over 50, being male, and carrying extra weight, especially around your midsection. Being a current or former smoker is another big one, and so is family history. If you have a parent or a sibling with Barrett's or esophageal cancer, that's a really significant factor.
And speaking of family history, just look at this number. For people with GERD who also have a family history of Barrett's or esophageal cancer, the prevalence jumps to over 23%. That's a huge leap, and it really shows you just how powerful that genetic link can be.
So what do you do with all this information? Well, the medical guidelines are pretty clear. The American College of Gastroenterology says that if you've got those chronic GERD symptoms and you have at least 3 of the other risk factors we just talked about, it's time to talk to your doctor about getting screened.
All right, let's say you and your doctor decide screening is a good idea. What does that actually involve? Let's decode the whole diagnostic process, how doctors find it, and just as importantly, how they grade what they find.
The main test, the gold standard, is something called an EGD. A doctor uses a very thin, flexible tube with a tiny camera on the end to get a direct look at the lining of your esophagus. If they see that telltale salmon pink tissue, they'll take a few tiny tissue samples, called biopsies, to get a closer look. Those tiny samples then go to a lab, where a specialist called a pathologist examines them under a microscope. Now, they're looking for very specific things, but the real smoking gun, the crucial clue, is the presence of something called goblet cells. These cells make mucus and belong in your intestine, not your esophagus. Finding them there is what confirms the diagnosis of Barrett's esophagus.
Okay, so once Barrett's is confirmed, the next question is about something called dysplasia. Now, this word just means the cells are starting to look abnormal under the microscope. It's not cancer. Think of it as a spectrum, a path of progression. It ranges from no dysplasia, where the cells have changed but still look organized, all the way up to high-grade dysplasia, where the changes are much more significant and concerning.
And that naturally brings us to the most important question of all. So what do we do about it? The really good news here is that there's a very clear playbook for managing Barrett's, ranging from simply keeping a close watch on it to actively treating it. The first step for absolutely everyone diagnosed is to get that acid under control. This is usually done with a type of medication called a proton pump inhibitor, or PPI. The goal is to reduce that constant irritation from the stomach acid, which can help prevent the condition from getting worse.
From there, it's all about surveillance. And the plan really depends on that level of dysplasia we just talked about. If there's no dysplasia, a checkup endoscopy every 3 to 5 years is typical. But as you can see, if you have low-grade or high-grade dysplasia, the monitoring becomes much more frequent. And we start talking about active treatment.
And wow, has treatment changed over the years? It used to be that if you had high-grade dysplasia, the only option was a massive surgery to remove a part of your esophagus. It was a huge deal. But now, the standard of care is something called endoscopic eradication therapy, or EET. These are minimally invasive procedures that remove or destroy only the affected tissue without major surgery. It's a total game changer.
And there are a few different types of these modern therapies. Radiofrequency ablation, for example, uses heat to get rid of the abnormal cells. Cryotherapy does the opposite, using extreme cold. And if there are any little bumps or raised areas, doctors can use a technique to basically shave them right off. The right tool is chosen for the job.
Okay, look, we've thrown around words like cellular change and cancer risk, and that can sound really scary. I get it, but I want to spend this last section on what is truly the most important takeaway. The outlook for people with Barrett esophagus is actually very, very good.
Let's start with the most common scenario. You have Barrett's, but with no dysplasia. What's your risk of it ever progressing to cancer? While the annual risk is incredibly low, somewhere between 0.1 and 0.5%, that's less than 0.5% per year. That is a hugely reassuring statistic.
Let me put it another way. Look at this chart. The overwhelming majority of people with Barrett's esophagus, we're talking more than 95%, will never develop esophageal cancer. The entire goal of screening and surveillance is to identify and manage that very small percentage of people who are at risk, and we have great tools to do that now.
And there's so much you can do to help yourself, too. Simple lifestyle changes can make a big difference in controlling the underlying acid reflux. Things like quitting smoking, getting to a healthy weight, and avoiding your personal trigger foods, the spicy or fatty stuff, can really help. Oh, and not eating for a few hours before you go to bed is a big one.
And let's end with this quote from a medical journal that just says it all. Basically, as long as the condition is managed and monitored properly, someone with Barrett esophagus should expect to live a completely normal life. It is a manageable condition, not a death sentence.
So, we've covered what it is, who's at risk, how it's diagnosed, and how it's treated. You now have the information, so the final question is really for you. Knowing what you know now about the signs and the risk factors, what's the conversation you're going to have with your doctor?